Okay, so our next speaker is Dr. Marco Hansgen. He is a social scientist, and from 2015 to 2018, he worked at the Centre of Tropical Medicine and Global Health in Oxford, but his position was also shared with the Said Business School in Oxford. As of January 2019, Dr. Marco Hansgen has joined Warwick as an assistant professor in global sustainable development. Dr. Marco Hansgen is a mixed method researcher in development studies, focusing geographically on Asia and thematically in context of marginalization and societal change. His research currently investigates the social context of antimicrobial resistance, which of course is a global health priority, exploring rural health-seeking behaviors, how people understand antibiotics and illness, their constraints in accessing healthcare, and the intended and unintended consequences of health interventions. So today, Dr. Hansgen is talking about the behavior within and beyond healthcare settings, for example, about the limits and problems of awareness raising and tackling drug resistance, or broader considerations on how to approach antibiotic use through behavioral sciences. So without further ado, Dr. Hansgen, the stage is all yours.
Thank you very much, Martin. Let me just share my screen. Should now be able to see my slides. Are you?
Yeah, I can see them now. Great.
Great. Okay, thank you. So thank you so much for the introduction, Martin, and thanks everyone for dialing in. Pleasure to talk to what I believe is a group of students primarily, but anyone who's interested. I hope we get something out of this. As Martin already mentioned, I will draw on my background in interdisciplinary research, especially in the social sciences, touching on medical research, touching on evaluation methods, touching on development studies, in order to give you a bit of perspective on how we would approach antimicrobial resistance from a behavioral and social science perspective. Now, as I do that, I will be broader than is conventionally the custom when we talk about the behavioral sciences. Behavioral sciences often evokes ideas of individual change, of nudging, of behavioral design, steering people subtly into a particular direction. That's part of it. I would argue that's not all of the behavioral sciences. The behavioral sciences extend much further than that, and you get an idea of that as I go along. As a matter of fact, why don't I start with that exactly? Because my first analogy to bring this point across, that behavior is something quite extensive. I have an analogy for you that links antimicrobial resistance essentially to climate change, right? In a way, they're very similar, right? It's like I'm not going to tell you that antimicrobial resistance is a global priority and across the world, and it's going to cost 10 million deaths a year by 2050, right? You know that probably. And if you don't, probably someone else will mention it at some point. But what antimicrobial resistance and climate change have in common is that we see it as a gradually evolving and catastrophic threat to the world. We'll touch on a second on what the world is that we're talking about here, but it's also a change that has been driven by Western practices that gradually spread around the world from the West through modernization, through what we call development, and has created, and some would argue in neo-colonial ways, dependencies between low and middle-income countries and high-income countries. And now, as countries had adapted to this process and were succumbed to it to some extent, now low and middle-income countries are particularly susceptible to the impact of the changes that we are expecting, right? So like you've seen COP26, you've been following the news, right? So like the outlook is catastrophic, right? And low and middle-income countries, they carry most of the burden, or at least they struggle hardest with it because of the distribution of costs as means of managing that. But also what we know from climate change is that everyone knows about it. We can raise more awareness about it, but they don't stop climate change, right? So the standard behavioral tools that we often use, the standard behavioral policy tools that we often mobilize or used to mobilize in the past, what's that? Education, incentivization, coercion through regulation. These are standard tools. They're not going to do much more than we've already done. Their potential is basically exhausted within climate change, right? In terms of like the policy options that we have, right? And we know that raising more awareness will not change anything because everyone knows climate change. There might be some small gains to be realized, but there's probably also other areas where we can realize yet further gains, right? Now, will this be the technical fixes? Well, to some extent, but they won't fly on their own. What are technical fixes? You wonder, well, in the case of climate change, carbon capture and storage, electric cars, lab burgers, you name them, right? But they are always implemented into a system populated by humans, and humans have to work out how we're going to use that. It's not going to happen magically, automatically, because technology. But also what the process of COP26 has made clear, and what's coming now to the fore because the threat of climate change is becoming so catastrophic, is that there are new movements arising, recognizing the limitations of past actions. These movements now are recognizing, for instance, in the context of climate change, the socio-economic and cultural impacts of past climate change efforts, of past area protection efforts for the matter. And how we have not seen a lot of unintended consequences, how we have crowded out, pushed away really important actors like indigenous peoples who had owned the space, protected areas before, and who are now regaining a voice because we so critically depend on them. And one could argue, this Marco guy is banging on about climate change. What the hell? We're here for antimicrobial resistance. But here's the thing: they are not very different, right? So I can read out the slide, but by and large, what are we talking about when we talk about climate change? When we talk about antimicrobial resistance, we're talking about the world of biomedicine being under threat. Now, whether that's the world of health and well-being more broadly, multidimensionally, that's another question. But biomedicine is very much concerned with itself here, that its key solutions to solving medical problems, the way it had grown up and matured, are now evaporating because drug resistance, right? And this has been a process that is not the sole responsibility of low and middle income countries, because biomedicine, through process of development, through process of globalization and modernization, has pushed its product, so to speak, around the world, right? And in this process, it crowded out previously existing systems of medicine and healing, and even making sense of what health and well-being is. Not altogether, but to a large extent. It positioned itself as superior. Now it's created dependencies on pharmaceuticals as care, which now has taken such an extent that biomedicine has threatened itself and now is saying, well, we have to manage how we use antimicrobials because they're losing their effectiveness. But it doesn't mean that therefore low middle income countries are the culprits, right? We have been pushing this product, right? So like biomedicine itself has a role to play in this as well. So we can't just point the finger. That's very important to bear in mind. And we'll come back to that, by the way. But also we see then that the measures that we use in order to, stimulate what's sometimes called more judicious use of antimicrobials, that these follow relatively limited behavioral mechanisms, right? So like, again, we have education and awareness raising. We have the word antimicrobial awareness right now, but also regulation, monitoring, incentive schemes for insurances. There's limits to what we can achieve with those if we continue sticking with standard tools of behavior intervention. And then, of course, there are the technical fixes that we're always looking forward to with their unlimited potential. But everything, the potential is always unlimited. Whether we realize it is a completely different question. Vaccines, diagnostics, phage therapy. There's lots on the horizon. Lots of it is already available. Because humans use technology, there's also limits to it, and we have to realize that. But then also, biomedicine have been crowding out, as I mentioned, these other systems of medicine, which are now regarded alternative medicine, as if the ultimate benchmark is always biomedical practice. But now they're coming back to the fore. Why? Because now suddenly we start realizing that we don't have to treat every ailment with a pharmaceutical, but there's actually other forms of healing, well-being, and maybe we realize that health is multidimensional, not just physical well-being and mental health, but also social and spiritual well-being. That other systems of medicine cater for perhaps more holistically. And like once we realize, then we start seeing that there's also other forms of treatment that then can reduce the pressure on using pharmaceuticals, including antibiotics, right? So like now these systems of medicine are being called to the rescue, as it were, almost to save modern medicine. Modern medicine has been pushing it out and discrediting these systems of medicine for many, many decades. So there's also some irony in there that we have to realize. Now, why do I tell you all this? The point is that this is a very complex environment, behavioral setting, that we can't just educate away in order to solve it. That won't work, right? And so I will talk about behavior, but I will relate it to awareness campaigns because it's an easy target and they don't shout back at me, at least not at the moment. So it helps us focus our thoughts, right? So one thing we shouldn't obsess then about is raising awareness, right? Now, I'm not saying don't do it, right? And like keep it a secret. That's also not what I'm saying. Awareness raising can be quite useful for several purposes. It can be useful to mobilize action. It can be useful to generate ideas, bring people together, have platforms like these right now where we can exchange thoughts and maybe even find solutions together. That's good that awareness raising does that. It can also indeed produce and provide some information that then actually steers behavior. But only to a very small extent. And we have known for 20, 30, 40 years that this is absolutely limited. Information sharing shapes behavior only to a very small extent. 20% of the decisions that we make are driven by us weighing reflectively information against each other and making a decision. And that's 20% of the decision of processes where we can make a decision. There are lots of behaviors where we don't even have a choice. Where we sort of like go with the flow because context. So education for awareness raising as a behavior change tool is very, very limited. And so in that sense, we shouldn't obsess about it. It also comes with a whole lot of problems, as you can see on this slide. It often starts from a premise that, well, I took this course, I learned this and that, I read this paper, and now I know something that I didn't know before. Now everyone else needs to know this because probably they don't. And if they don't know it, they must be wrong. It's not always in those lines, in those terms, but often de facto in practice, it materializes like this. We talk at people, tell them what to do without bothering to find out what they're actually doing at the moment and where is it coming from. And it can be really patronizing. It can actually provoke the exact opposite reaction of what we want to achieve. It can backfire. We come back to that. But also, the value of awareness campaigns for behavior change is systematically overestimated because we don't evaluate it properly, especially in fields like public health. Now, there are, of course, excellent public health specialists who are very sensible about communication strategies, but there's also a lot of hot air out there. And we have to be careful about how people evaluate or assess the effectiveness of an awareness campaign if the objective is to change something like behavior. If it's just for the intrinsic value of knowing more, okay, fine, right? But if we have an awareness campaign and we just want to find out, do people now know more than they knew previously about the very subject that we told them? And that's the only thing that we bother asking about, then it's not an evaluation, then it's just confirming our own biases. What we also need to find out is, do behaviors actually change? What else do people take away from it? How do they interpret the messages that we give them? And are there some unforeseen behavioral consequences that now emerge from people exercising their agency with the new information that they have? Or misunderstanding something, because it happens all the time and we don't have control over people's thought process, however much some people might like that, but we don't. And so there's also an evaluation issue here. But what's the biggest problem about awareness campaigns to steer behavior is that this is often driven by the idea that the main behavioral driver of the problem that we're seeing here is that people don't know enough. The knowledge deficit logic. Remember this now and now forget it again. Never think about knowledge deficits again, because it's a really, really problematic and again, patronizing and very hierarchical way of engaging with people and trying to understand behaviors. The knowledge deficit logic has been debunked 50 years ago. So don't define behavior change through awareness raising, because you would just use very outdated reasoning that is not up to scratch. So what then? Should we not do education and awareness raising? Well, we can do it, right? But we have to be aware that there are limitations. If we wanted to do it, we have to realize that there's very little to gain from it if it works, because everyone automatically jumps almost as a first impulse into raising awareness, into educating the problem away. You'd be surprised how often you see people diagnosing a problem and then say, well, what should we do? Well, we should educate people. It's very, very common. It's almost ingrained in people's reactions to a problem. It's intuitive, right? It doesn't mean that it will solve the problem. But if awareness raising worked, well, then there are two possible scenarios here. One is that we have solved the problem already because there's a lot of awareness raising out there, right? I mean, we would have solved climate change if awareness raising worked to solve a problem. But also, if awareness raising worked, then we would not have these discussions any longer, because people would have stopped doing awareness raising for behavior change because we learned 50 years ago that it doesn't work. Okay, but again, I mentioned that's specifically for behavior change. If we wanted to achieve other goals like mobilization, building political capital, having calls to action through the welcome trust, this is a different story, right? It's like they make sense on different terms. And we can have small gains too, right? 20% of our decisions are steered by information. There might be training, there might be factual information flowing at us. But in the worst case, if we don't consider the limitations of awareness raising, we might create the illusion of action, making a lot of noise, but diverting funds to something ineffective, diverting attention to something ineffective, but also time, and delaying more effective possibilities from the behavior science spectrum, for instance. But also we risk producing some unintended consequences, as I mentioned. And you'd be like, but I mean, antimicrobial resistance, World Health Organization, surely they don't do that. But look at these examples here that I have for you. You see some of the campaign materials from this year and earlier years of the antimicrobial resistance awareness weeks. And you see the first poster, for instance, like the first GIF animated, is saying, spread awareness, stop resistance, always take antimicrobial medicine like antibiotics, antivirals, antifungals, antiparasitics with proper medical oversight. Who's even the target audience here? Well, it seems to be the general population, patients, maybe people who are sick right now. It's not quite clear. But someone apparently who understands scientific language, because these words will not make sense for many people. At least the people would not be very aware, at least in low-income countries where I work, what those things are. And I imagine many of my friends wouldn't, even here in high-income contexts. So there might be a context issue in terms of like, are we even speaking the same language? Simply because we want to be precise doesn't mean that it's meaningful nuance for our audiences, right? Then we have on the right-hand side a poster that says, well, you have your role to play. Wash your hands properly if you want to avoid antimicrobial, or if you want to do your part in reducing antimicrobial resistance evolution. Now, what do you think will happen? Do you think people will now see this and wash their hands? Or do you think they, when the next time their hands are not clean, they will think about antimicrobial resistance and wash their hands extra long? I don't think that's going to happen. So we have to have a concept of where and when behavior happens when we want to share information. Same with safe sex, right? This might not be a context where people think about antimicrobial resistance. So we want to be really clear about what is the behavior that we want to influence, and are we using the right tools for steering this behavior. But also what we can see in this poster is this really, really problematic patronizing of populations. You see it in the middle bottom panel here. Let me use my laser pointer. Laser pointer here, this guy is, this is borderline offensive, right? We simply assume that people eat antibiotics like candy. Have we bothered to understand whether they even know what an antibiotic is, whether this is anything by choice? There are a lot of assumptions out there, and simply putting something out there can alienate your audiences because you didn't understand where behaviors are coming from. And if you then do that, then things can really backfire, right? You can cause more harm than good through an awareness campaign that you set up in order to actually improve behaviors. Well, what can go wrong, right? I mean, like, look at this picture here, which is from a hospital in Southeast Asia. One thing that can go wrong is that we assume that people haven't had any other awareness campaigns that are out there. There are hundreds. People are being bombarded with information. Why do you think that they would hear what you have to say in all this noise that's raining down onto them? Even if you target it to your audiences, like here, the sales counter for medicines that people pick up from the hospital. Even there, you have conflicting information from awareness campaigns. Look here on the right. Okay, so like this is the antimicrobial resistance awareness. Don't take antibiotics mindlessly, don't pop pills, is more or less what's saying, like stop eating them. You have here a doctor with a stethoscope. If you're not entirely literate, functionally literate, you might struggle with what it's trying to tell you, but maybe you get, okay, here's a big stop and eat medicine. Okay, so far so good. And then, idly your eyes wander over and then you see this. Well, what's this telling me? This one's telling me, well, lots of medicines. This is a happy mouth eating a medicine. Oh, that looks good. Maybe I should eat more. This one is encouraging people to have supervised medicine use, because if you go to private doctors, you might get a shot and you don't know what's in there. Directly conflicting information if you don't digest it in with the full nuance that was initially intended. And then you have these coordination failures, okay, and they can really confuse people. What else can go wrong? I mean, we can look at the agricultural context, for instance, but Henry in the next session will tell us a little more. But what happened here is a study, a beautiful study by Finbo and Jensen, published in Social Science Medicine, where they did research on antimicrobial resistance with pig farmers in Denmark. And they didn't initially aim to focus on that, but in their research, in their ethnographic research, it became really clear to them that there's an issue going on. There was an awareness campaign about antimicrobial resistance, saying that a lot of antimicrobial resistance comes from pig farms. Arjen Dierik earlier told us that there's a lot of antibiotic use in chicken farms in Thailand. Well, here in this case, it was in pig farms in Denmark. Now, what happened? People took that information, some people anyway, and processed it and thought, okay, we have to do something about this. Okay, mobilizing action. What kind of action did they mobilize? They printed leaflets that said, well, don't have sex with pig farmers because they carry deadly bacteria that can't be cured. Now, I don't think that was intended by the awareness campaign initially, but this is one of those unintended consequences that comes out of it, right? We cannot control this, but we have to be aware that it can backfire, right? And so, like, don't have illusions, don't be naive when you want to change behavior, and especially when you want to put out information there. It can and will be interpreted in different ways. And in our own research that we did in Southeast Asia, similar things happened. Right? We were prepared, and we also assessed this broad spectrum of behaviors that come from it. Now, we had workshops with villagers in Southeast Asia, northern Thailand, southern Laos, and we shared information that the World Health Organization would say is useful information to share. Like, don't share your antibiotics with your neighbor, only get antibiotics from a doctor. That's what the World Health Organization would say. And so we also related them to participating villagers and workshops in 5 villages. So we did that. We also then measured whether they subsequently felt they knew more about antibiotics, and yes, they did. Okay, but the story didn't stop there. Then we also checked whether their behavior changed and what else happened. We also did some qualitative research, and now it turns out that people with that information that they gained felt more empowered about their handling of Western pharmaceuticals. So empowered that one of them then said, well, I know what I'm doing, so let's stock up in my shop these medicines that they were talking about and sell them, because I now know what I'm doing. Of course, we didn't tell them to sell medicines, right? But people possess agency, right? And we can't deprive them of that. Heavens, no, we should not even think about that. But they will process information on their own terms, right? Of course, we then told them that that wasn't what we intended. But you can see what can come out of information sharing and awareness raising, right? And this is nothing new, right? I'm not saying anything revolutionary new. We've known this for 10, 20, 30 years. If you need some backup for this argument, here's a reference, right? They will give you a nice portfolio of unintended consequences that come about with health communication. And I say it again, there are many sensible public health communicators, specialists who know about this, who engage sensibly, listen to the audiences, try to understand what's going on, be empathetic. That's how we should do it. But we should not talk top down, don't eat antibiotics like candy because it might really annoy your audiences, right? Instead, what we should be doing is take a breath, take a step back, and try to understand where's the behavior coming from that we think is so problematic. So I want to share with you a little bit of what we learned, where this behavior is coming from, what it looks like in the first place anyway, from our research in Southeast Asia. This was research that involved development studies, engagement with social and contextual change, and how it then affects healthcare practices, health behaviors of patients in particular, or general populations. Now, sometimes we looked at this through the lens of antimicrobial resistance, but sometimes we looked at broader health behaviors. What do people do when they're sick? Sometimes we looked at medicine use specifically. Okay, so there's a range of projects that that we've been conducting with colleagues, including Arjan Direk, who just talked to you, in Southeast and Southeast Asia. Okay. And now one useful way of then thinking about where is this behavior taking place is to think about an activity space. I'm not saying you have to use this framework, but this is how it helps me think anyway. And this activity space basically is, in this case here, the interface between patients and healthcare systems. Now, it doesn't have to be patients and health systems, right? Henry will talk about more economic agents and agricultural production, right? We can also frame it in those terms. But here's one way of thinking about it. Now, the patients, we know, even before we start doing research, we know that patients' health behaviors are really complex, right? Often syncretic, meaning that they combine different healing traditions in one process, even if we as outsiders might think that's illogical. But it also takes place in reaction to local contexts and environments, hardship and adversity of it. Then we have the healthcare providers, right? Now, they might be doctors and nurses, but it can also be healthcare, informal healthcare providers like grocery shops or your neighbor who provides care. But if we look at health services, where we have to be real and realize that they're humans, right? And they also face struggles from below, from patients who might, look at them with puppy eyes and like, please help me, doctor. From above, the middle management who needs them to meet the performance targets, the key performance indicators, like Dirk mentioned. But then also in this mess, they have to make sense of their job, have to enjoy it, follow the guidelines with a rubbish salary of it. Right? So like we also have to recognize their constraints. And then interfacing them is a network of solutions. There might be information circulating around. It might be cars and other technologies, vaccines that connect patients to the health system. Now, the important thing here is that whenever we intervene with a new intervention, awareness raising or diagnostic tests, it will never be in a vacuum, right? There's already something there. People already solve problems somehow. And we are now interfering with those existing solutions. And that might create, again, unintended consequences. And then we have the broader system itself, which might then also be subject to external influences, for instance, global health discourse. So what's then behavior in the system? Well, we see, as I mentioned, syncretic health behaviors. No need to say more about that. Specifically in the context of Thailand and Laos, where we did most of the research here, but also India and China, rural India and rural China, we see that socio-technological change, development, if you want to call it that, has implications for how people behave when they're sick. More affluent people are directed towards private healthcare because it's more performative, but people might also be getting more antibiotics there. But also we see that mobile phones, for instance, and social contacts facilitate access to antibiotics. And specifically, when people suffer from precarious livelihoods, when they have a really hard time in their life, in the job, and they really have to keep going no matter what. It's a shitty situation to be in, right? But mobile phones then give you a way out because they connect you to the nearest source of stuff that keeps you going. It can be antibiotics, but it can also be shoots like this. Like these are little like bags of medicine where there's an antibiotic, but there's also like steroids and ibuprofen, aspirin, and all other sorts of stuff that make you feel good. Okay. Technology facilitates it. Can you educate it away? It won't be easy, I tell you that. Right? But also, if we ask simple questions like, did you actually use an antibiotic? People might not understand what the hell you mean, because again, context, right? In Thailand, in Laos, people don't talk about antibiotics in terms of the antibiotic, right? It's the technical term that people don't use. In Thailand, they might be talking about anti-inflammatory medicine when they mean antibiotics, but doctors might be reluctant to use the term because it means something else for them. and then no one communicates with each other. In Laos, if we ask people about antibiotics, then you get a valid response about 30% of the time, and other times people refer to medicines with a direct name, say Ampi for ampicillin or Tetra for tetracycline, and they might not know what an antibiotic is, but they know they want Tetra. But if you don't have an awareness campaign, you might be missing the target completely, because then people choose not to use antibiotics, but it doesn't mean for anything to them anyway. And so they feel compliant, but are actually not doing what you want them to do. That's why you need to understand the local context. Same with healthcare providers, right? So like you have pluralistic healthcare systems where there's a lot of informal healthcare providers, and your neighbor might be sharing their medicine with you, and it might be an antibiotic because they care about you, not because they want to circumvent guidelines or because they don't care about drug resistance, but because they care. You have an allergy, they want to help. Right? That's not easy to educate away, especially if it's the auntie, right? Who wants to help? Now, what do you do then? It's tricky, right? But even if you look at the formal healthcare providers, it's difficult, right? You have, on the one hand, a very clear awareness that there's a thing called drug resistance, and people know generally that this is a problem, right? You can raise more awareness and more help. On the other hand, they have to balance this knowledge with these social, ethical, and epidemiological dilemmas that they're facing, right? It's like they don't know whether someone might be developing a co-infection from the current condition, so we better give antibiotics preventatively, right? We want to earn this out of caution, right? That's a very difficult decision for someone to make, but that's probably the least uncomfortable decision they can make in this context. And so people get more training, especially nurses and doctors in Northern Thailand, where we did research. But this training that they're receiving is then colliding also with community norms on what should be care and how you connect with the patient. Whether or not they want antibiotics in particular, maybe you just want to give them something in order to show that you care. But then also monitoring comes in, coercion. And what happens? What happens is that then people start falsifying data because they cannot make do. You try to force them into a particular behavior that doesn't work for them because you didn't bother understanding where it's coming from. And then we have the interface, right? Diagnostic tests being introduced, but again, they might not be hitting the right behavior in the local field sites. Like here, what you see in the picture, a diagnostic test for antibiotic for C-reactive protein testing for fever patients. Now, that was implemented because the literature said, well, many fever patients, they don't have malaria, get antibiotics. But it didn't really add up in Thailand, where this test was introduced, because people didn't want antibiotics for fevers. They don't, not in that area anyway. They might want an antibiotic for other symptoms that come with fevers, but it's not for the fever itself. And so the target group was kind of misguided because we didn't bother, or we didn't spend enough time understanding the local behaviors. Awareness campaigns confused the hell out of people because it used technical language that people don't use. It was a different language, literally, even though it was Thai in both instances in Northern Thailand. I talked about the quick fixes already, but then we also have the broader system again, where we then also have the influence of pharmaceuticalization coming in globally. So I don't need to repeat them, but also bear in mind that in this campaign that we have, in order to reduce antimicrobial resistance, we focus on antibiotics very often, right? So that's the Northern agenda, as it were, because what we're focusing on is this red and black pill here in this cocktail that is really toxic for people. So if we take this out, then it's all fine. Job done, we walk away, right? The problem is still there. The antibiotic wasn't here the biggest problem. The problem is that people take really toxic cocktails of medication just to keep going because the environment is so precarious, so toxic onto themselves already. Again, we have to understand the context and the behavior and also what agenda is being pushed here. Okay, so that was the backstory, right? So like, let's get a little closer to how do we then actually do behavior and how we think about it. I had mentioned already that the knowledge deficit logic is one small aspect of the behavior change spectrum. And if anything, it's completely exhausted, right? Everyone's already jumped on the behavior change, on the knowledge deficit train, the global action plan for antimicrobial resistance. The first objective was to have a massive global public awareness campaign, right? Okay, the ground's covered. If you want to do something meaningful, don't start there. Okay, nothing to gain. But then there's a broader spectrum of behavioral sciences approaches that we can then also consider. Now, as I mentioned, often they're being considered in terms of nudges and sort of like cognitive processes that happen in our brain. Now, they can be really effective to augment also, especially awareness raising campaigns to actually, provide information in a way that actually steers people into different behaviors, making also sense of cognitive processes. But that's not all, right? It's not all just happening in our heads, this behavior. There's also broader context at play as well. And this is also where we can use behavior science frameworks that were designed specifically for that. COMBI is one of them, and we'll come back to that. And now this is a growing field. So like there's actually a lot of work happening, and you see a growing number of reports talking about behavioral insights in this field of antimicrobial resistance, but not only, also, for instance, in climate change policy. But then there's also broader sociological and political sciences end of the spectrum, where we can still continue, where we can still continue considering behavior. Behavior is a form of resistance, for instance. Behavior is response to adversity, to precariousness, for instance. Now, this is where the behavioral sciences, narrowly defined, struggle a bit, right? They don't have social theory to back up what does it mean when someone is experiencing precarity. And what is precarity? What's vulnerability? How do they experience this through intersectional disadvantage? Racial discrimination, right? It's like that's not easily captured here, but is more easily captured through social theory and the political sciences, sociology, anthropology, history. But it can also help us understand what, for instance, the colonial roots of current behavior are and how we should not intervene. So that's then also very important to consider. And that was one of the reasons why I then also brought up the climate change analogy, because there's a lot of historical baggage that we're carrying around with us that we also have to be aware of if and when we want to intervene, so that we don't just, pretend history didn't happen at all. So we have COMBI. COMBI is a simple and a useful framework for behavior change analysis and design. And that's a very precious combination. Not many frameworks are simple and useful. There are many simple frameworks, but they're not very useful, and they're very complicated frameworks that no one will ever use. COMBI is a good combination of that. Now, to keep things simple, let me show you this picture here instead. COMBI basically says that behavior, what we have here, is shaped by people's capability, whether they can perform a particular behavior, their abilities, if you will, the opportunities, sort of like the context, environment around them, physical as well as social, and motivation, knowledge, but also, the automatic cognitive processes happening in the background. COMBI, K-C-O-M, leading to B, right? You get the idea. So this is a very simple 3 or 6 dimensional framework that can help us make sense of what's current behavior, what are current interventions trying to change behavior, what are they emphasizing, but what are they missing, and where can we still work on? But then also to design future interventions, looking at what are the barriers and enablers across these different dimensions. It can be really useful. If you're craving some examples, here are some of them. But take it with a grain of salt, because again, behavior sciences in practice is often relatively narrow, focusing or foregrounding changing the individual. If you look at the broader social sciences, you find much more inspiration also for changing the context, which will become much more relevant when we talk about complex issues like climate change, like antimicrobial resistance, right? You can't blame the victims eternally to change their behavior to fix climate change. Like there has to be broader structural change as well. But this might give you some starting point anyway. Now, what's important if we want to use behavior science logic is that we base it on very systematic and thorough analysis. It's not a brainstorming process. It doesn't happen on your desk. It's not an armchair exercise. Okay, I'm running out of cliches. You have to do the legwork. Here's one more. But the important thing really is that you ground your analysis in the local context for it to make sense. You can't do it secondhand, right? So how can we then use it? So as I mentioned, we can use COMBI in order to categorize existing behaviors, what's happening in the field, how it is structured, what physical and social constraints are people experiencing when they behave, and what's preventing them from behaving in another way. But we can also use it to, for instance, synthesize a range of interventions that are already happening. Now it's been done, for instance, with antimicrobial stewardship campaigns or also awareness raising campaigns, right? So like we can then look at what are the activities, emphasize what's missing, and what's missing is more often than not context. But we can then also use the behavior change logic to design interventions, right? Now, when we do that, it's important that we don't start with the assumption that we know what's best for people, right? That's an assumption. We have to ground it in actual evidence that what people is doing is problematic, and what has to change is something in the immediate environment or in the broad environment. We have to establish it, don't assume it. And once you have then actually established it, it's again not a game of pick your favorites of what's my favorite intervention type and then push it onto people and see which category of combi does it tick. You have to do combi analysis and then find out what's the best combination, the best portfolio in order to change behavior. So the process would then look something like this. Okay, let me speed up the animations because time. I'm not going to read out the slides, so like you can follow up by email if you want to have a copy of these slides, but you see it in any behavior change publication anyway. It's like there's a systematic process that you have to go through. But what I would caution is specifically here at the beginning, from the broader social sciences perspective that I'm telling you here, is that really clear your assumptions away at the very beginning, right? So like you wanted to raise awareness, well, scrap that, right? And then again, right? And then really do the stock taking exercise of what is it that you want to achieve and what's currently happening in that direction and why do people behave that way? And social scientists, and I don't mean economists or psychologists, but anthropologists, medical sociologists, development studies, they can help you understand what's happening on the ground. Okay, do ask them. You have to work interdisciplinary for all of this to make sense. And so like, then we can come up with a list of examples of what might be the different factors that prevent, define current behaviors or enable the behaviors that we want to see in people. There's a spectrum, right? I will not read them out here because there's only so much you can do out of context, right? So like, again, you can look at these slides, but you can do an easy Google search and find lots of examples from these behavior insight studies of what they found in their concrete context, and then emulate it, finding out what matters in your context. But what we need to avoid is these knee-jerk reactions, right? We really have to do our research. We have to work interdisciplinary in order to make this work. So the bottom line is, should we then not raise awareness and educate? And again, that's specifically for the purpose of behavior change. For other purposes, I didn't talk about them, right? If you want to create political capital, probably is a good idea. If you want to change behavior, then don't educate and raise awareness if that was the first thing you came up with, because then it's probably a bad idea. Then you have to clear your assumption and go through the behavior change process, behavior design process. But also don't base your expectation of education will be really good this time, really, based on what everyone around you is doing. If they're all doing behavior change through education, then there's no justification for you to do it as well, right? But also we have to check our own privilege, right? Because often we do armchair reasoning because we are in a more privileged position than people who actually have to carry the weight of the behavior to be changed. So again, you have to be empathetic. But there might be instances where then our behavior analysis tells us that information sharing might be a good idea, or maybe people even request it themselves, right? Okay, then it makes sense to have an awareness campaign to devote resources to that. But we also have to have a really good understanding of what are the other behavior drivers, and is it really a good idea to include in here an awareness component, or should we rather direct our attention in other directions? Okay, so here's a to-do list then for you going forward. Okay, we're almost at the end, and thanks for bearing with me. First is clear your assumptions about how you change behavior, right? So like scrap knowledge deficits, scrap theory of planned behavior, because you will come across that and it's not functional, right? It's been superseded by combi, by all behavior change, current behavior change interventions, because it wasn't up to the job, right? So scratch those. And instead, acknowledge, own it, that you don't know fully what's happening on the ground. You have to do the research, and you have to use, for instance, combi to analyze what's happening on the ground, when and where is behavior happening that you want to change. Step 2, then also reconsider how you behave, right? So like we have to rethink can learn from the behavior science because they have been banging on about this for 50 years, right? Time to listen up. Let's not repeat the mistakes of the past. So we can't just react into behavior change. We have to respond to what's actually happening locally. Right? We have to do it respectfully. We have to do it with full acknowledgement of our privilege. Maybe we have to take a step back. Maybe it's not our task to do at all. But then also we have to think not just in terms of single solution of our favorite pet intervention that we want to make ourselves famous for, but we have to think in terms of portfolio. What's the best tailored package here in order to achieve our targets, right? And then also evaluate it comprehensively so that we are aware of the unintended consequence that it brings. And thirdly, we have to broaden our horizon, right? We have to look into the void there of what are the other behavior change techniques that I hadn't ever considered because I'm really uncomfortable with them. And very likely they will extend into structural change rather than individual change, right? It's like stop victim blaming, stop patient blaming. They might not even know what's going on. And awareness won't fix that because people are reacting to a hardship. They might be suffering from pain and despair that's driving them into behavior. Then alleviate the pain and despair rather than telling them what to do. Right? Sometimes you can change behavior without with people being entirely unaware. But what could other measures be? Infection control, for instance, because infection control, like infectious environments, are often a driver of antibiotic use in clinical settings in low-middle-income countries. Big problem. Substitute away from that. Building community capital, community social capital, community cohesion, but also financial and institutional social protection schemes, debt relief, because people struggle with debt, household credit, basic income schemes, but also occupational support, sick leave. They can all alleviate this experience of precarity that might be driving people into antibiotic use, knowingly or unknowingly. But we can also look into the domain of agriculture that Henry might tell us more about in the next talk, right? But you will likely find that this exceeds your own capabilities. Then reach out and don't just fall back to, okay, the only thing we can afford is an awareness campaign, so we do that. And again, you divert attention away from more important things, also your own attention, right? So like you have to work across sectors, you have to work across disciplines. So here we are, then at the end of it. Thank you for bearing with me. That was a long talk, but I'm glad you listened in. In a nutshell, it's a complex problem, right? Complex behavior problem that we can't educate away. We can't educate away climate change because we already know about it, or everyone, but you also can't educate antimicrobial resistance away. Right? But what we need is to exploit the remaining potential of behavior change mechanisms. And there's plenty out there still that we haven't yet tapped. Behavioral sciences tools, behavioral insights tools are expanding in their weight in the policy space in AMR, but there's also further structural tools from sociology, medical anthropology, political sciences that we can recognize as behaviors, resistance, living conditions to drive people into behaviors that seem irrational, but are perfectly plausible, but our response to hardship, right? But in order to do that, we have to have a more diverse space. I shouldn't be talking to you here as a white guy because it should be more inclusive, it should be more diverse. This talk about antimicrobial resistance, it shouldn't be a medical topic, it should be a human development topic, as it were. And so when we then also intervene, we have to be respectful, we have to be engaging, empathetic, try to understand, and don't be invested in the idea of having to intervene. Right? And explore then the range of also structural options that might be more difficult and might be long-term, but are really important also as we come out of a pandemic, as we go into the post-COP26 period of trying to fight for the habitability of this planet. There needs to be structural change. But what you need to avoid absolutely is perpetuate this poor and outdated practice of thinking behavior is driven by what people know. It's driven to a very small extent, to an extent that almost doesn't matter any longer because we have already raised awareness. Okay, so go beyond the theory of planned behavior, look at the behavior sciences tools, work interdisciplinary on complex issues like antimicrobial resistance. I'll leave you with that. You have my email here, I think. I leave that slide up for just a second in case you want to get a copy of the slide deck. But anyway, happy to continue the conversation. And if you have any questions, shoot. I will somehow stop slide sharing. Yeah.
Thank you, Professor Hensken, for that very interesting talk. I think you mentioned a lot
Please
of...
tell me that my microphone was on.
Yeah, it was on. Don't worry.
Okay, very good.
It was very interesting. I think you mentioned a lot of very good points that the Trinity AMR action group can also take on. I
Great.
especially found the combi stuff quite interesting and about sort of taking a more holistic approach to behavior. So I think we can definitely take that on in the future. So of course, as you said, we're open to questions for a few minutes. Just to sort of start us off, I actually had a question, not so much on specifically AMR awareness, but I wanted to know your opinion regarding Insulate Britain. I don't know if you've heard of them. They've been on the news quite a lot recently. I wanted to know, their approach to trying to change behavior. What do you think about it?
I have to admit I'm fairly ignorant about those developments. So like I would need a little more backdrop
Okay.
to give you like an intuitive response, but I haven't made up my mind about them. I only read some headlines.
Sure. Yeah, no, that's fine. All right, thank you. So of course, if you have any questions, please feel free to put them in the Q&A section at the bottom. Um, and we'll just give it a few minutes for some questions. Great. Um, so at the moment, I don't think I'm seeing any questions for anyone at the moment. If it's okay with you, I think we can leave it there for today.
Absolutely.
So
Feel free to share my email in
sure,
the chat
sure,
if
of
people want to
course,
follow up.
sure, we'll
But
do.
thank you so much for having me and for providing this platform and for participating in this event. It's very nice. Thank you very much.
Yeah, thank you for your time. It's been great seeing you today. So for our audience, we'll be taking a short 10-minute break until 10 past 12 for Professor Henry Buller's talk on antibiotic use in livestock agriculture. So please stay on. Just grab a coffee in the meantime if you'd like, and we'll rejoin at about 10 past 12. Thank you, everyone.